Steroid preparations are by far the most widely used product. They're fast acting, they work, you can use them for, you're only meant to use them for short periods of time. They inhibit epidermal proliferation, they damp down the inflammation, and they're available in different formulations. You can get them in mousses, gels, lotions, and those are all quite useful for hair-bearing areas. The problem is that they can cause steroid side effects, particularly the very potent ones. The steroid foams and short contact shampoos are meant to give you less steroid atrophy because of the shorter contact time. You don't see steroid atrophy with the moderately potent steroids such as beta-methazone valerate or beta-methazone dipropionate. One problem with steroids is that they tend to be in formulations which will come onto the face, and that can induce steroid-induced side effects on the face directly, such as steroid-induced rosacea. The published evidence for them, however, is very, very good, and they clear the psoriasis, particularly the strong ones, very quickly. But if you look, where is it? After a while, the efficacy rates drop off. So as a long-term solution for treating and managing scalp psoriasis, they're not ideal. Also, the very strong shampoos, the very strong lotions and shampoos, the clobetasol propionate, induce not just the atrophic steroid effects, but can also cause scalp folliculitis. So this young lady is very happy using her Claire Lux shampoo, but she won't be happy when she develops a scalp folliculitis. Calcipotriol application, Divonex, works well, but is hampered by the fact that is only available as an alcoholic preparation, therefore it'll sting, and it can often exacerbate any itching or irritation that the scalp psoriasis is already causing. But published studies show that it works quite well. Coal tar solutions and dithronol have largely fallen out of favour in the UK because they are quite messy and quite smelly. But when they do work, they give quite long-term remission. This is a study which compared calcipotriol scalp application and tar or dithronol. And you got a good clearance with a calcipotriol, almost 60%, and a reasonable clearance with the tar shampoo, 36%. The tar emollient at 36%. So, when they do work, they can give you sustained clearance, but the nature of the product means that patients don't like using it. And it's been a long time now since I've prescribed a tar product specifically to treat scalp psoriasis. These are two examples of coal tar. You can see a 10% one there on the black one, and the slightly beige coloured one is, I think, is a 2%. So you can see why compliance is quite poor with these products if your patient has to apply these to the scalp. We have two dithronol products, Dithro Cream and Myconol, and as shown in this photograph, they leave quite a heavy staining on the skin. So, Xamiol gel is oil-based and therefore a good descaler on its own accord. It, like its body comparator, Divobet, has superior efficacy compared to the steroid or the vitamin D analog on its own. And there's no evidence of skin atrophy at 12 months if used on a regular basis. It's also very cosmetically acceptable. There are a number of published studies showing it show that it has a fast response, has rapid onset of action, is well tolerated with very few side effects, and fairly good clearance rates, 68.8% in that study, and better than the calcipotriol or beta-methazone alone. The largest study by Van der Kerkhoff again showed good clearance rate, 68.4%, rapid onset, low incidence of side effects. And Luger in 2008 published a study comparing it with calcipotriol at 52 weeks, and showed good clearance, 92%, minimal or absent disease when Xamiol is used regularly, and a high patient satisfaction, 76%. Lower for calcipotriol, but the product causes irritation and can sting, hence the lower satisfaction rates for the patients. We have quite a large steroid phobia amongst our patients, and that is not helped by our pharmacists or our GPs. there are only 500 dermatologists in the United Kingdom, and I hear there are roughly 500 dermatologists in Israel, and your population is about 7 million, and my population is 66 million. So the most patients who have a dermatological condition are seen by general practitioners, and only a small percentage are actually seen by dermatologists. General practitioners get just a few days training of dermatology in medical school, which they take forward to general practice for the rest of their life. So their knowledge of dermatology is quite poor and is coloured, and they are very apprehensive on using new products and very apprehensive in using topical steroids. And the patients are apprehensive about using topical steroids. The pharmacist is apprehensive about using topical steroids. So generally, the only person who's not apprehensive is a dermatologist, but they never get to see one because we see so few patients compared to what we could potentially see if there were more of us. The studies show with both Divo-Bet and Xamiol gel that steroid atrophy rates are very, 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 very minor, and it's safe to use on a long-term basis. Quality of life, significant improvements when using Xamiol. Now, the gel is best used overnight. It's quite a liquidy, oily substance, and you can squeeze it on or spoon it on. You need to rub it into the affected areas. I ask the patient to wear a shower cap, so they put the product on, put a shower cap on, and go to bed. So the patient is pleased that I've taken interest in their scalp psoriasis. The patient is also pleased I've taken interest in making sure that their pillows aren't stained by the Xamiol gel. So it's a good relationship I'm developing with my patient. So the occlusion of the shower cap may actually help enhance the effect of the product. The studies show that the gel clears patients rapidly within a couple of weeks. In clinical practice, if you're using things like shower caps to occlude the gel, you're probably going to get faster clearance rates than that. In the morning, they need to wash the Xamiol gel out, and it's very important that the patient uses a shampoo to help lift out the Xamiol gel, but the important thing is to make sure they put the shampoo on before they wet the hair. So when the hair is still dry, put the shampoo on, massage the gel out, and then rinse out with water. If they wet the hair before they put the shampoo on, they'll spend all day trying to lift the gel out of the hair. So it's very important that you tell that to your patients when you're prescribing this product. It's a key message with the product. Otherwise, they'll be back the following week. Oh, doctor, I've used the product, but it's too oily and I can't get it out of my hair. And they may have lost faith in you in your prescribing of this product if you fail to mention that before they start using it. So it's an example of a patient with a baseline scalp psoriasis, and then 8 weeks later, from the Xamiol gel, all cleared. For patients who have more unresponsive disease, occasionally I've used a systemic agent such as methotrexate and cyclosporin. Biologics are probably inappropriate for this condition. I've yet to prescribe one for scalp psoriasis. There is some evidence to show that the Xamiol laser is effective at clearing psoriasis. But if you look at the number of treatments, up to 52 treatments, in private practice, you're probably earning quite a bit of money, I think, if you're to buy one of these and using it to treat scalp psoriasis. UV combs are available, and you can even buy them over the internet. Biologics cost more than a house, yet phototherapy is more effective. I've yet to see a UV comb actually work at clearing scalp psoriasis. Waste of money. Non-adherence to treatments, particularly dermatology treatments, is a big problem that the UK Health Services is focusing on. We have a lot of patients who get prescriptions and hardly ever use them, throw them in the bin. And that's a big waste. And in dermatology, there are examples of up to 40–50% of patients simply not using the products that they've been prescribed by their dermatologist. In economic terms, that's very expensive. But in human terms, that's tragic that the patient has gone to the effort of actually consulting a doctor, getting the prescription, but not actually using the product. If 40% of patients are non-compliant, then it's fairly reasonable to assume that the commonest cause of treatment failure is probably non-adherence. Now, there are lots of reasons why patients don't adhere to using their product. They may quite like having their disease. They may be forgetful, lazy, unsure about the medication, find the medication too complicated to use. And when it comes to psoriasis, using a complicated regimen of descaler, shampoos, active product is quite complicated. And so if you've got a product which is just a one-stop shop, which will provide an effective treatment but is simple to use, then that will improve compliance rates. And Xamiol gel does tick a lot of those boxes. It's a daily use, so it's simple and convenient. It's patient-friendly with low irritancy. It's odorless and colourless, it's patient-friendly. Doesn't stain the skin, and there's negligible steroid atrophy, so that should reassure the patient about using a product which contains a steroid. And it's fast-acting, which will motivate the patient to use it, and obviously effective. So in summary, it's a descaler, does not require pre-treatment, it's fast-acting, highly effective, and in clinically proven long-term safety. And certainly over the last 2 years of using it, my patients have found it a very easy product to use. Sometimes for patients with complicated schedules, I'll give them written information sheets or printed handouts. And we developed some for general practitioners, to say, because lots of patients don't have access to dermatologists, and often these GPs give out these information leaflets which are meant for their education to the patient, to help show them how the product is meant to work and how the product is meant to look like at week 1, week 4, week 8, and so on. We also developed one for Xamiol as well, again to help the patient and the GP show how the product should be used and what to do if it's not working well. Sometimes I simply just write it down on a bit of paper and say, this is your diagnosis, this is your treatment, and this is what to expect. The reason why I do that is that, as you can see, at the top there's my name, my website and everything, and when the patient's visiting friends, or you saw Dr. Downs and what have you got? Well, I'll just get that bit of paper. He's written the diagnosis down for me, and it's got all my addresses there. So if the treatment's worked out well, then hopefully their friend will come and see me because they've got all the information there in front of them. Treat the rest of the body, and don't think of the scalp in isolation, and vice versa. Thank you for listening.